talking about basal ganglia disorders is going to be our way to learn about the basal ganglia. Rather than going into blah, 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 all the details about the basal ganglia, we talked briefly about its function in the last section, and now we're going to talk about disorders. So by talking about the disorders, I'm hoping to clinically ground the information to have it make more sense. And then later on, if you're just dying to know more about the different loops in the basal ganglia, you have a base to work from. So that's what we're trying to do here. So only one learning objective for this section, and I want you to be able to describe the signs and symptoms, pathology, and etiology of Parkinson's disease and Huntington's disease. Lovely pathology boxes in the chapter on both of these things. Parkinson's is considered a hypokinetic basal ganglia disorder, and Huntington's is a hyperkinetic basal ganglia disorder, and we'll talk about the individual ones. So movement disorders in basal ganglia dysfunction range from hypokinetic, which is too little movement, to hyperkinetic, which is excessive movement. So remember, the basal ganglia are trying to control our desired movement and inhibit undesired movements. And so if it's too inhibited, we have too little movement. If it's not inhibited enough, we have excessive movement. Differences in abnormal movements are due to dysfunction in the motor pathways within the basal ganglia and in the PPN, which is one of the basal ganglia structures. So Parkinson's is the most common basal ganglia motor disorder, and I'm sure you've all heard me go on and on about Parkinson's because I work with a lot of people with Parkinson's disease. So it's a really interesting area to me. When I was in neuro, when I was in school, I did my project on someone with Parkinson's disease that I was working with in the clinic. I learned so much from this person, and I have continued my fascination with Parkinson's disease ever since. And let's see, what year is it? 2020? So 6 years ago, I got certified in LSVT Big. I'm an LSVT Big certified clinician, and I am the lead for our LSVT Big program at my clinic, since the previous lead who started our program has retired. So I work with a lot of people with Parkinson's, and it remains an area of extreme interest for me. So I will try not to talk too much about it, but I will hit the high points. So Parkinson's disease consists of two common subtypes. In our text, they call the one subtype postural instability, gait difficulty, or PIGD. It's also more commonly known as akinetic or rigid type Parkinson's. And the other type is the tremor dominant Parkinson's. The prevalence of each of the subtypes, akinetic is about 50%, tremor dominant is about 40%, and then mixed, where you have both, is 10%. And so the treatment is going to be similar for both, but you're going to have different considerations, whether it's akinetic or tremor dominant. So the akinetic subtype, or the PIGD subtype, is characterized by muscular rigidity, drooping posture, muscular tremors, rhythmic tremors, and a mask-like facial expression. People with akinetic Parkinson's have difficulty coming from to standing from sitting, and this is in more advanced stages of this. Their gait is characterized by flexed posture, shuffling, or festinating of feet, and decreased or absent arm swing. In Parkinson's classifications, there's a scale of Parkinson's, which you'll learn more about in your neuro rehab class, which is the Hone and Yar scale, and so there are different classifications by how much people are affected. So with the early onset, you might have the tremor is usually the thing that sends people into the neurologist. Usually they don't develop the gait abnormalities until later on. The distinctive signs of akinetic Parkinson's It's also called classic Parkinson's or classic idiopathic Parkinson's. That's what you'll hear in the clinic. So you can think of TRAP as the distinctive signs. Tremor, rigidity, akinesia, and postural unsteadiness. So tremor is a resting tremor. Rigidity is that muscle rigidity, and it's often that lead pipe rigidity that we talked about. Akinesia, which is also known as hypokinesia or bradykinesia. Hypokinesia meaning less movement, and bradykinesia meaning slow movement. And postural unsteadiness, so postural difficulties. And knowing the functions of the basal ganglia, all those make sense, right? So akinesia and bradykinesia can include freezing during movement or freezing of gait. They'll call it fog, F-O-G, freezing of gait. Visual perceptual impairments, because there's actually a sensory motor disconnect in Parkinson's. The mask-like facial expression, and then lots of non-motor signs, because we know that the basal ganglia are responsible for a lot of non-motor effects. And so a lot of times people have Parkinson's, the neurons that produce dopamine are dying off in Parkinson's, and that's what causes the symptoms. A lot of times people have the non-motor signs for years and years before they start having motor signs, but they don't know that those non-motor signs are signs of Parkinson's, and it's the motor signs that send them in to get checked. So there's a whole list of non-motor signs, and we're not going to talk about all of them, but they are very common in people with Parkinson's, but most people don't know that those are caused by the Parkinson's. With tremor and freezing, the resting tremor is a hyperkinetic sign, but that frequently shows up with the akinetic Parkinson's. People with akinetic Parkinson's often have episodes when their movement abruptly ceases despite the fact that they're trying to do something else, known as freezing of gait. Sometimes I call it the floor glue. It's like your feet are glued to the floor. You just can't break it. And it's not really known what causes freezing of gait. And there are a couple strategies that you can use to overcome freezing of gait, but it's not an easy thing to deal with. So a lot of times, once someone's frozen, if they try to move against the freeze, it's hard for them to do it. So what we have them do is we have them stop, take a nice deep breath. They might do some side-to-side movement with their feet to break the freeze, and then you're going to step out with a big step breaking out of the freeze. So it's really challenging. It's a very difficult thing to deal with. People get stuck in doorways and stuck different places because of freezing of gait. So it's one of those really challenging symptoms. People with tremor-dominant Parkinson's experience both resting and action tremors. There is a link to a video in the module of Michael J. Fox talking about his tremor-dominant Parkinson's. And if he really focuses on it, he can damp down his tremors. But and he talks about it in the video. And but if he doesn't focus on it, he really has a lot of tremor. The rigidity and slowing of movement in tremor-dominant Parkinson's are relatively mild. And people with tremor-dominant Parkinson's experience a slower progression of signs and symptoms than those with akinetic Parkinson's. So because the symptoms are a little bit different, they don't see as much of the signs that disrupt your life, basically. The pathology in Parkinson's is the death of those dopamine-producing cells in the substantia nigra pars compacta, and also acetylcholine-producing cells in the pedunculopontine nucleus. So it's not just dopamine, it's dopamine and acetylcholine. But the cell death occurs long before the clinical signs of Parkinson's become evident. So by the time you see clinical signs of Parkinson's, 80% of the dopamine-producing cells have died off. So it's a long, slow progression. So probably people's dopamine producing cells started dying off when they were in their 20s, and they don't see symptoms until they're in their 50s or 60s or even later. There is such a thing as young onset Parkinson's when people have onset in their 20s or 30s, and that is less common. So um, there are treatments besides therapy, obviously, for Parkinson's disease. The medications that replace dopamine are initially effective, but the longer you're on the medication, the sooner you're likely to have side effects. So the side effects can be hallucinations, delusions, psychosis, and dyskinesia, so disorganized movements. And the progression of the disease with the involvement of other cells and neurotransmitters limits the effectiveness. So the dopamine replacement drugs, so Sinemet, the chemical name is carbidopa levodopa. Sinemet is the trade name that you'll see, and that is what most people are on with Parkinson's disease. The more of the acetylcholine cells that die off, the dopamine replacement drugs don't have anything to do with the acetylcholine. And there are some acetylcholine drugs, but they have much worse side effects. And so it's almost not worth it to take them. Most people do a cost benefits analysis and the cost is too high. There is an invasive procedure called deep brain stimulation where there's a neuronal transplant that is implanted in your brain to help control movement. Unfortunately, deep brain stimulation works early on, but people with DBS tend to lose swallowing and voice control sooner than people without DBS. So I guess you have to decide if it's worth it to do that. I've worked with quite a lot of people with DBS, and it's helpful. Neuronal transplantation, there are some stem cell treatments for Parkinson's. Again, they don't last forever. There are some researchers at Kyoto University in Japan who last year in 2018, November of 2018, successfully transplanted someone's own neural stem cells into their substantia nigra. And a year out now, a year and a couple months out, the person is having good effects from it. So that could be a future treatment. Destructive surgery of certain structures can sometimes help with some of the symptoms. That's purely treating the symptoms. It doesn't cure the disease. All of these things purely treat the symptoms and don't cure the disease. Physical and occupational therapy improve mobility and functional status in individuals with Parkinson's. Intense resistance training produces greater muscle hypertrophy and functional gains than standard exercise. So up until even as late as 2012, the American College of Sports Medicine was recommending, don't exercise too hard with Parkinson's. But now they know that intense exercise is beneficial in people with Parkinson's. So a lot of exercise programs have developed in recent years. There's one that's called Pedaling for Parkinson's, where people do a spinning class basically at very intense levels. There's Rock Steady Boxing, which is a boxing program for people with Parkinson's. So lots of things. And LSVT Big, which is the program that I do, is large amplitude movement training. And the focus is on amplitude. There's also a companion voice program that goes with LSVT Big that's called LSVT Loud, and it helps work on people's voice status, which is really great. So the take-home message with this is people with Parkinson's not only can work really hard, they should work really hard. Intense treatment is really important for people with Parkinson's. So there's a collective name for primary neurodegenerative diseases that have signs similar to Parkinson's, but they are not Parkinson's. They're called Parkinson's plus syndromes. So the reason they're classified with Parkinson's is because they have similar motor effects but different pathology and etiology, and also a different prognosis. Primary neurodegenerative disease indicates that the cause is idiopathic or genetic. So the syndromes that are included in the Parkinson's Plus group include progressive supranuclear palsy, or PSP, excuse me, Lewy body dementia, and multiple system atrophy. So all of these are included as Parkinson's Plus syndromes because they have symptoms similar to Parkinson's, but it's different etiology and pathology. So with Parkinson's Plus syndromes, red flags that indicate a different diagnosis other than true idiopathic Parkinson's include early postural unsteadiness. So people with true idiopathic Parkinson's, whether it's akinetic or tremor dominant, they don't get postural unsteadiness until later in the disease progression. Rapid progression of signs. So people with Parkinson's Plus syndromes have much more rapid progression of signs. Respiratory dysfunction, in some of them, abnormal postures, uncontrollable and inappropriate laughter or crying. So there's some emotional component, or signs of cerebellar, corticospinal, or voluntary gaze dysfunction. So a lot of times people will go in, they'll get diagnosed as Parkinson's, and then they're not responding to the Parkinson's meds. And the reason they're not responding to the Parkinson's meds is because there's a different pathology going on. So with PSP, a lot of times you see early onset of gait instability, the tendency to fall backwards, a lot of axial rigidity early on. You get axial rigidity in idiopathic Parkinson's, but this happens early on. Freezing of gait early on, depression, psychosis, and rage attacks, and what they call gaze palsy. And a description of gaze palsy, sometimes they call it doll's eyes, so like those old-fashioned baby dolls where you lie them down and their eyes closed and you sit them back up and their eyes open. So people with PSP, they have that gaze palsy, and it can be very difficult for family members because it's hard for them to meet someone's eyes because someone looks at them and they'll automatically look down. So Lewy body dementia causes early generalized cognitive decline, visual hallucinations, and Parkinsonism, which Parkinsonism is usually the description for the motor effects normally associated with Parkinson's disease. So Lewy body dementia is a sad disease. It's sort of almost like if you were to cross Alzheimer's with Parkinson's. So you have the cognitive decline of Alzheimer's and the motor decline of Parkinson's. Sad, sad. And I've worked with some people with Lewy body dementia. They can improve their mobility with therapy, but it doesn't do anything to slow the disease process. Multiple system atrophy is a progressive degenerative disease affecting many areas of the brain. It's actually PSP, LBD, and MSA are all degeneration of the tau proteins in the brain, which are structural proteins. So the brain is actually breaking down structurally. And MSA affects more areas. And so a lot of times with people with Parkinson's Plus syndromes, we are working on assistive devices. We are working on patient education. We're educating the patient and their families about what to expect in the future, and it's not a good prognosis. Parkinsonism encompasses disorders that mimic the motor signs of Parkinson's disease, but the cause is known to be toxic, infectious, or traumatic. It's often a side effect of drugs that treat psychosis or digestive problems. It can be traumatically induced, like someone who's a boxer or something that someone in a brain injury or repeated brain injuries. Drug-induced Parkinsonism frequently leads to misdiagnosis and unnecessary treatment for Parkinson's disease in older adults. So it's not Parkinson's disease. It's not treated the same way. Signs include bilateral onset with rapid progression. So with idiopathic Parkinson's, it's usually unilateral onset. With Parkinsonism, it's bilateral onset, rapid progression, early postural tremor, and involuntary movements of the face and mouth. Hyperkinetic disorders, abnormal involuntary movements are characteristic of Huntington's disease, dystonia, Tourette's disorder, and dyskinetic cerebral palsy. In dyskinetic cerebral palsy, it's the basal ganglia that are affected in development. Huntington's disease, the signs include chorea, which is involuntary writhing movements, and eventually dementia. It's an autosomal dominant hereditary disorder that causes degeneration in many areas of the brain, most prominently in areas of the basal ganglia and the cerebral cortex. Most people who have Huntington's know that it runs in their family, and a lot of them often know about it before they get the symptoms. There is genetic testing you could do to find out that you have Parkinson's. I'm sorry, Huntington's. With dystonia, it tends to be genetic. It's usually non-progressive. They're movement disorders that are characterized by sustained muscle contractions. It can cause abnormal posture, twisting, and repetitive movements. The abnormal movements often increase during activity and emotional stress, and they completely vanish during sleep. The tremor is frequently associated with dystonia. There's a form of dystonia that's called focal dystonia. And when someone has focal dystonia, MRI shows somatotopic degradation in the somatosensory cortex and in the somatosensory part of the thalamus. So it's like you lose your brain map with dystonia. Really interesting. Tourette's disorder is a hyperkinetic basal ganglia disorder, and it causes vocal and motor tics. It involves abrupt, repetitive, stereotyped movements. People with the disorder are aware of nearly irresistible sensory urges that precede tics. Stress, emotional excitement, and fatigue exacerbate the tics. And tics can be temporarily and voluntarily suppressed, but the urge to tic builds during suppression. The onset is during childhood. Dyskinetic cerebral palsy, involuntary abnormal movements are abnormal muscle tone and abnormal posture with involuntary movements include choreoathetosis, which is that involuntary writhing movement, and it's developmental damage to the basal ganglia.